Dr. JIGNESH PARIKH, who is a medical director at Shivam Eye Hospital, Vadodara, Gujarat, and he is going to show us something interesting, maybe can raise some controversy. On to you, Dr. JIGNESH.
Thank you, madam. Good evening, everyone. And today I am showing two cases of managing posterior polar cataract. Madam, I am audible?
Yes, yes.
Okay.
Very much.
Yeah, thank you, sir. So this is a case of posterior polar cataract with grade 3 nuclear sclerosis. So doing inside out hydrodelineation, I am initially doing trenching of the central nucleus, and now I'm doing inside of hydrodelineation. Now I have to emulsify the nucleus, but the only challenge is I can't dial the nucleus as not to give any pressure to the posterior capsule. And so I am trying to crack and emulsify the nucleus as much as I can. Here I'm keeping all my phaco parameters very low. I'm doing as much as I can. Now maintaining the closed chamber technique. I'm injecting visco before removing my phaco probe. I'm rotating, or I'm doing the flipping the posterior or sub-incisional part as to emulsify, and bringing in the AC and in the center. I'm emulsifying it. Here every time I'm maintaining the anterior capsule or anterior chamber, and I'm trying to see that there is no pressure over the posterior capsule at any given moment. Here the epinuclear plate is very thick, as I have done inside out hydrodelineation. So instead of doing removing with IA probe, I will be doing with phaco probe only from the periphery. So I'm trying to remove the peripheral parts of the epinuclear plate as much as I can without giving any pressure to the central posterior pole. And same closed chamber technique is maintained every time. Yes, I'm removing as much as I can from the periphery. All right, closed chamber technique maintained before removing phaco probe, injecting phaco visco. And now the main part is to separate the posterior capsule from the epinuclear plate. I am injecting dispersive viscoelastic, and now the things are very easy for me, so I can do easily. This is a second case, bit a challenging one, as patient is told by two renowned surgeons that this is a clear-cut phaco posterior polar cataract. So same, but here the nucleus is very soft. So instead of emulsifying, I will just aspirate the nuclear part with phaco probe. But here also I will not rotate anytime, not to give any pressure to the posterior pole or posterior capsule. Same way, the epinuclear plate is very thick, so trying to remove by my phaco probe only as much as I can from the periphery without damaging the center part. Closed chamber technique is maintained. And now to separate epinucleus from the posterior pole, posterior capsule, I'm again trying to remove the epinuclear plate from the other sides. Still,
what happened?
What happened? Anyway, I think he has shown quite well. It was he has tried to show inside out hydrodelineation and going forward. Now, I have just one question here. If we already know, we have done an ASOCT, and you know that there is a PCR in this particular case, besides the option of doing a femtocataract platform, which would ease up the manipulations in these eyes, if you were to do a straight phaco and you know there's an open capsule, what would be the extra things you would do? Dr. Mohan, Dr. Malay, any one of you could tell me?
Okay, if you know that there's a pre-existing
Yes. Yes.
dehiscence of the posterior capsule.
Yes.
Okay, if you don't have access, of course, I do femto, but
Yes.
if you don't have access to femto,
Yes.
what I would do is the same parameters. I would prefer to use a Centurion machine. The simple reason, I have better intraoperative control with active fluidics and IOP control. Everything is much better. If you don't have access to Centurion machine, it doesn't make a difference at all. So what is important is to lower down your parameters and now and then inject, make sure that you inject a good viscoelastic like Viscoat and come out of the eye and keep the parameters low. Do not try to rotate the nucleus and make sure that when you remove the last piece, that is the epinucleus, you make sure that you put a Viscoat underneath that, and then you probably, if there is a pre-existing, obviously there's going to be vitreous there, and put tricot and then go ahead. Usually this dehiscence, the pre-existing dehiscence which is there, it is not like a typical posterior capsule rupture. It is like a two pillars on the posterior capsule. It will be two parallel lines.
Yes.
So
Yes.
that's what I think is very important for you to, you can actually, if you see that, if you have IOL master 700, you can actually see it preoperatively. You can see those delineation on the posterior pole of the lens very clearly. And the parameters are very important. Only thing is you should have a plan A, plan B, and plan C as far as IOL implantation is concerned. Tell the counseling of the patient is very important preoperatively also, and don't go for, don't promise them any premium lenses. I would prefer that if it's a two pillars, go for a multi-piece lens in the sulcus and capture the optic into the rhexis margin. So, yeah.
Anything else? Anybody has any point to add? Most importantly, don't allow the anterior chamber to shallow and ensure that the hydrostatic pressure in the bag remains same. There is no fluctuation on the bag, and that would may not prevent the epinucleus or any of the cortex to be dropping into vitreous, but you could salvage most of it, and you might get away with just a clean PC tear, and you can do an anterior vitrectomy. Dr. Malay, you are not there. Dr. Manisha, anything to add here before we go on to our last speaker?
No, ma'am, it has been a wonderful set. I just want to give feedback from all my PGs and all they're watching. It's wonderful. Thank you so much, ma'am. It has been really amazing. Thank you.